Hello, dear friends. Our attendees are joining, and we are going to start Advanced in Midwifery by Dr. Edson D'Souza and me. This course will be bilingual, Persian and English. Join us. We are waiting. Hello, dear friends. Our attendees are joining, and we are going to start Advanced in Midwifery by Dr. Edson D'Souza and me. This course will be bilingual, Persian and English. Hello, dear friends. Our attendees are joining, and we are going to start Advanced in Midwifery by Dr. Edson D'Souza and me. This course will be bilingual, Persian and English. Hello, dear friends. Our attendees are joining, and we are going to start Advanced in Midwifery by Dr. Edson D'Souza and me. This course will be bilingual, Persian and English. Hello, dear friends. Hello, dear friends. We are going to start our class, Advancing Midwifery, in next few minutes, and our attendees are joining us. Hope to see you. This course is by Dr. Edson D'Souza and me, Leila Mustafi. Hello, dear friend. Welcome to Advance in Midwifery. Our course will be start in few seconds. This course will be trained by Dr. Edson D'Souza and me, Leila Mustafi, in two languages, Persian and English. Welcome. Hello, dear friend. Welcome to Advance in Midwifery. Our course will be start in Hello, dear friend. Welcome. دوستان عزیز، ما تا 1 دقیقه دیگه کلاس مامای پیشرفته با مدرک لیگ اکسلنس سنتر مورد تایید وزارت بهداشت نیوزلند و با مدرس دکتر ادسون دسوزا شروع می‌کنیم. مدرس. دوستان عزیز، ما تا 1 دقیقه دیگه کلاس مامای پیشرفته با مدرک لیگ اکسلنس سنتر مورد تایید وزارت بهداشت نیوزلند و با مدرس دکتر ادسون دسوزا شروع می‌کنیم. دوستان عزیز، ما تا 1 دقیقه همونطور که ملاحظه می‌فرمایید این کلاس دو زبانه انگلیسی فارسی هستش و ما این کلاس رو استثناءً به خاطر همکاران عزیز ایرانی دو زبانه تدریس می‌کنیم. منتظرتون هستیم. به امید دیدار. همونطور که ملاحظه می‌فرمایید این کلاس دو زبانه انگلیسی فارسی هستش و ما این کلاس رو استثناءً به خاطر همکاران عزیز ایرانی دو زبانه تدریس می‌کنیم. منتظرتون هستیم. به امید دیدار. همونطور که ملاحظه می‌فرمایید این کلاس دو زبانه انگلیسی فارسی هستش و ما این کلاس رو همونطور که ملاحظه می‌فرمایید این کلاس Hello, am I audible? Am I audible? Oh, okay, I see. Yeah, your voice is echoing. Yeah. How's my voice now? سلام دوستان عزیز، خوش آمدین. Hello everyone. Hi Gail. Hi Irene. Hi Dr. Edson. Nice to see you. Miss you so much. We are so happy to see your glowing face, Irene, again. I'm so happy your husband came back healthy and our family get happy again. I'm making you unmute, but I don't know.
Okay.
Oh, yeah.
It's working. Can you hear me?
Yes, yes.
Yeah,
Yes.
I have a new computer, so it should do. It was donated to me, so I'm feeling very good. Yes, it was very challenging going through the hospital on the different side of it as someone supporting someone through the medical side. A lot to be learned. I think having ventured through it, I can see how our nursing has become more observant on machine than on the patient.
Yeah, that's true.
Yes, it led to me taking my husband home. We discharged against medical advice and we fixed him at home. So he's now running around and very healthy from being very, very stressed within a hospital setting. So we have a big mission ahead to improve our healthcare services. And I think that the universe put me through this twice, once with an operation for myself and then my husband getting sick, to really realize the changes that we need to make happen. So we are very lucky with Lily Excellence and people like Edson and Gail and Ricardo and you know, and all of you beautiful young midwives or obstetricians or doulas, because you're the future. We are sharing our expertise with you, but you will have a lot to give to us because we all bring such wonderful things and life's experiences. And the beautiful thing about this is that we reaching here today across many countries and many continents.
Correct. Yeah, that's wonderful. That's fantastic.
So what time is it with you guys? We are 3:30 in the morning.
And now it's 9 p.m. in India and 8 p.m. in Iran. And Gail and Dr. Edson, I don't know. Hi, Gail. Welcome. Dr. Edson, welcome. Hello, everybody. Thank you for joining us. We are going to start our session in few seconds. Just let's introduce our scientific board. Miss Irene Chain from New Zealand, Gail Johnson from Canada, and Dr. Edson from Brazil. Thank you so much for joining us, and we are going to start our session today. Today's session will be two language, Persian and English, and I hope English language guys bear our talking in Persian. سلام دوستان عزیز، همونطور که ملاحظه میکنیم ما داریم کلاس رو شروع میکنیم. خانم ایرن چین از نیوزلند و خانم گیل جانسون از کانادا و آقای دکتر ادسون دسوزا کنار ما هستن از هیئت علمی لیدی اکسلنس سنتر. من امروز خدمتون هستم، خدمتون سعی میکنم فارسی هم براتون مطالب رو بگم تا انشاءالله براتون جا بیفته. لطفا در طی کلاس ویدیوهاتون روشن باشه و حتما اسم پروفایلتون با گواهیتون یکی باید ثبت بشه با ایمیلتون. Please, if you don't mind, keep your video on. We want to see your beautiful, shining, smiling face. And if you have any question, write in the chat box, please. In the end of the session, we will answer to you. So we from Lily Excellence Center. We are a multinational organization headquartered in London, UK. Our expertise lies in OB/GYN midwifery services of global standards. We offer OB/GYN family health and midwifery services to clients from various countries, offer training and certification to aspiring midwives, healthcare professionals, and caregivers, conduct workshops to generate awareness on the benefit of natural birth and midwifery, family health, SRHR, support woman empowerment, and work tirelessly in all related field to achieve our ultimate goal, the betterment and progress of mankind. So in these classes, there is a chance to interact with the pioneers in the industry, listen to their experiences, and get an insight into the challenges, success stories, progress, and opportunities that are unique to this line of work. You can participate and share your own experience if you wish, or simply sit back and get an understanding of how we work. You can ask questions, inquire about certification if you find yourself thus inclined, or simply spend your time gaining knowledge about the field that is gaining momentum across the globe. You can reach us at the further details in our Facebook Lily E Center, Twitter Lily E Center, and Instagram Lily E Center. So hope to see you for next program. And tomorrow we are going to have yoga session as an account of International Youth Day. Okay, Dr. Edson, welcome, and we will start with you. Dr. Edson, if Gail, you want to have some welcome words to our attendees, Irene as well, and then we reach to Dr. Edson.
Well, I just want to say hi to everybody, and nice to see all the lovely young girls again. It's amazing, makes my heart good every time. I'd like to learn about hypertension, how it just pops up a bit more. I have my own ideas on it, but I always find a new idea and a new tip by coming to these classes. So here I am.
Thank you so much, Gail. Irene, you want to have some welcome words to guys, please?
Yes, I love talking about hypertension, and my role in midwifery over the years became very holistic, and I focused on the prevention of it and catching it early and turning it back to normal. So I'm going to help with a little bit of a discussion on nitric oxide. And I've got a document that I can post up so Lily can share it afterwards. It's part of my new textbooks. I've just got IBSN numbers for my 5 midwifery textbooks, which will be soon available on Kindle.
Lovely.
So I'm very excited that these books will be out very, very soon, because I think that they're going to be the foundations of the future.
Fantastic, fabulous. We are always proud of you, Irene. Thank you so much for being with us. You are one of the member of our wonderful Lily family. Thank you so much. Thank you. Okay, now we will reach to Dr. Edson, and our brilliant Dr. Edson, that everyone is sharing his wonderful evidence-based practice with you guys. Thank you, Dr. Edson. Welcome, over to you. Yeah, I make you unmute now. Yes.
Hello, everybody. I'm very happy and very glad to be here again. Last month we didn't meet anyway, and I would send my best regards for you, Fatima. You are here, Irene and Gail. I'm very glad to meet you again. And I hope you can meet every month as we have agreed before. Today, we will talk something about hypertension in pregnancy. I'm very glad to hear from Irene about prevention. We know that we can prevent preeclampsia, but today we will talk something about hypertension when we didn't prevent it, and this way we have to treat and have to manage it in the best way in order to prevent maternal and fetal and neonatal problems. I will share my presentation.
Yeah, sure. Please, doctor. خب دوستان عزیز، پس همگی لطفاً ویدیوهاتون روشن باشه. Please everybody, if you don't mind, write in chat box from which city, which country you are joining us. We like to hear from you. And I will try to share this PowerPoint through email to all of you. Don't worry. دوستان عزیز، این PowerPoint رو براتون شیر میکنیم توی گروه. لطفاً توی چت باکس بنویسین از کجا جوین شدین، از کدوم کشور، از کدوم شهر. Yes, please.
Okay, is my presentation in the screen? Yes?
Yes, doctor. Yes,
Can you
yes.
see?
It's visible, doctor. Yes. Go on, please.
Well, then my name is Edson Borges de Souza. I live in Brazil, and I will talk to you something about hypertension and also the experience I've built along all over my life in treating and managing this condition. I've been used to work in a big hospital in Brazil, and we have many cases of hypertension. And we have to admit that this is a very important subject because hypertensive disorders accounts for around 2 to 8% of pregnancies. They occurs in these pregnancies. And it is a big problem for mothers because maternal mortality associated to hypertension reaches around 40,000 deaths each year. And this is yes, it's a very large number.
Can I translate, doctor? Sorry interrupting you.
Okay.
Sure. همونطور که میدونید فشار خون حاملگی یکی از کامپلیکیشن های بسیار خطرناک در دوران بارداری هست که 2 تا 5% بارداری ها رو میدونین که هایپرتنشن در بر میگیره و ما حدود 40,000 مرگ مادری داریم. آقای دکتر اسون سالها در بیمارستانی کار میکردن که بسیار با این موارد درگیر بودن و تمام اینها رو بر اساس شواهد بالینی و اسناد خودشون و از طریق evidence based خدمتتون ارائه. Yes, doctor, please.
And it accounts for around 30% of all maternal near-miss events. A near-miss event is when the mother don't die, but almost died. This is a very important indicator too. And a big problem for babies too, around 16% of stillbirths, iatrogenic prematurity, fetal growth restriction, and so on.
از 16% مرگ‌های نوزادان هم به خاطر این مسئله فشار خون حاملگی هست. حتی 30% مشکلی که برای مادران در ماترنال در مادران ایجاد میشه نزدیک 42 تا 10,000 تا آمار میزان خطر خیلی نزدیک حتی نزدیک به مرگ رو داره. پس تقریبا در سال ما در مادران حدود 40,000 تا مرگ رو در سال در مادر میبینیم و در کودکان حدود 2.6 میلیون مرگ رو در استیلبرت مرگ تولد مرگ جنینی رو داریم. Yes.
Preeclampsia is a very complex disease. It can be challenging to manage it even for very experienced professionals. Then in order to properly manage it, we need at least 3 points. To know the scientific evidence related to the disease, to its pathology, to have good clinical skills, and also to apply a good method for diagnosis and treatment.
همونطور که میدونیم پرکلمسی یک بیماری بسیار پیچیده‌ای هستش که حتی برای پزشکان و متخصصین با سابقه هم دچار مشکل میکنه. به خاطر همین ما برای اینکه بخوایم مدیریتش بکنیم ما نیاز داریم حداقل دسترسی داشته باشیم و بدونیم در رابطه با شواهد ساینتیفیک و علمی که مربوط به این بیماری هست. همچنین ما باید مهارت‌های کلینیکال خوب داشته باشیم و باید یک روتین و یک متدی برای تشخیص و درمان اون اجرا بکنیم. Yes.
Well, today we will talk just about this method, this routine We will not lecture about the treatment of the emergency crisis prevention or even treatment of convulsions. I think we can do this in a future meeting.
Yes. این جلسه ما فقط در رابطه با در این کلاس امروز ما صحبتی که می‌کنیم در رابطه با متدهای روتین و تشخیصی صحبت می‌کنیم و جلسه آینده که انشاءالله هفته آینده هست در رابطه با پیشگیری و درمان کانوالشن یا تشنج صحبت خواهیم کرد. Yes.
And I think this lecture will be useful mainly for those people who works inside a hospital and manage patients with hypertensive diseases there.
این لکچر و این درس خیلی کمک میکنه برای عزیزانی که در قسمت کلینیک های بارداری و قسمت فشار خون های بارداری ویزیت میکنن و با این بیمارها در ارتباط هستن و کلینیک ها رو دارن مدیریت میکنن. Yes.
And maybe you can think to know this kind of skills and knowledge is exclusive for doctors. No, this is not exclusive or only useful for doctors. Midwives, nurses, and everybody who works with pregnant women may know this kind of knowledge, may have this kind of knowledge.
این اطلاعاتی که شما اینجا امروز دریافت خواهید کرد فقط برای پزشکان نیست، برعکس باید تمام از افراد گروه پزشکی و درمان مثل ماماها که با مراجعین باردار در ارتباط هستن کاملا درش مهارت پیدا بکنن و بتونن مدیریتش بکنن.
Well, in these situations, we have here 5 steps, and I call this the 5 steps and 5 questions approach or method. We have to follow these 5 steps. The first one begin with the gestational age. Second, establish diagnosis. It's really preeclampsia. We have other kind of diagnosis. Third, if preeclampsia, does it threaten the pregnant woman life or the fetus life? That means, is it severe? There is end organ compromise. Fourth, can we wait or may we proceed to delivery? This is the 4th question. And the 5th, if we have to deliver, which is the best mode of delivery? Can we deliver the baby vaginally or may it be a C-section? These are the 5 questions, the 5 steps. If we follow these 5 steps, we will know what to do with this woman.
5 تا مرحله و 5 تا سوال هست که به عنوان کادر درمان شما باید در نظر بگیرید تا بتونید به مسیر مراقبت درست دسترسی پیدا کنید. اولین سوالی که باید بکنید این هستش که سن حاملگی کی هست. اولین استپ و مرحله. دومین مرحله باید تشخیص و دیاگنوز رو بیاین ایجاد کنید، پیدا کنید. یعنی تشخیص‌های متفاوتی پیدا میشه، تشخیص‌های افتراقی رو کنار بذارید و ببینید آیا واقعا این پرکلمسی هست یا نه. مرحله سوم شما باید به این مرحله برسیم که اگر این پرکلمسی هست آیا خطری مادر و جنین رو تهدید میکنه یا نه. اگر شدید هستش و یا این که داره در انتهای آسیب زدن به ارگان‌ها هست مشخص بشه. در استپ 4 باید تشخیص بدیم که آیا میتونید صبر کنید یا باید کمک کنید که مادر سریع زایمان کنه. یعنی آیا میتونید شما اکسپکتنت منیجمنت یا مدیریت نگهدارنده بارداری رو داشته باشین یا خیر. باید ختم حاملگی. و در مرحله 5 کدوم مدل از زایمان رو شما برای مادر پیشنهاد خواهید کرد. Yes.
Then let's go. Step 1, define gestational age, because our decisions will be based first on the severity of the disease and secondly on gestational age. We have to know that the first trimester crown rump length is the best way for determining gestational age and should be used whenever appropriate.
اولین استپی که باید انجام بدیم این هستش که سن حاملگی رو تشخیص بدیم. خب برای سن حاملگی همه شما میدونیم که ما معمولاً بر اساس سن حاملگی میفهمیم که میزان خطر و جدی بودن خطر چقدر هستش. لذا اولین اقدام برای تشخیص درست سن حاملگی بررسی کرام رامپ، طول کرام رامپ یا طول سر، قسمت بالای سر تا استخوان کوکسیک بچه هست در تریمستر اول که بهترین پارامتر هست که شما بتونید جستشنال ایج درست رو در بیارین که معمولاً این دیگه مطمئن ترین روش هست که شما بتونید درست سن حاملگی رو تخمین بزنید بر اساس اولین سونوگرافی. Yes.
Then if you are inside a hospital and you have to talk about a patient who has hypertensive disease, the first phase, the first step to know gestational age. Secondly, to establish a diagnosis, the differential diagnosis, is it really preeclampsia?
دومین مرحله این هستش که شما تشخیص رو مشخص کنید، استبلیش کنید، تشخیص‌های افتراقی رو پیدا کنید و ببینید آیا واقعا این پرکلمسی هست یا خیر. Yes.
We know that preeclampsia, and I'm sure you know that, has been defined as hypertension developing after 20 weeks of gestation and proteinuria.
همونطور که میدونیم پرکلمسی معمولا به این صورت تشخیص داده میشه که با فشار خونی که بعد از هفته 20 حاملگی همراه با پروتئینوری باشه پیدا میشه. Yes.
Indeed, it's very easy if you think on the resources needed to make this kind of diagnosis. We need only two things: an equipment to measure blood pressure, and a dipstick to see if the urine of this woman has protein.
تنها راهی که خیلی راحت و ساده هست برای تشخیص خیلی راحت هستش همون فشار خونی هستش که شما میبینید که سیستولیک بالای 14 و دیاستولیک بالای 9 هست و اینکه همراه با پروتئینوری هستش. Yes.
In July I was on vacation and I went to the Amazon region in Brazil. And I visited many very distant cities, and there are people who live there. And I told them, even here, we don't have high technology resources here, but even here we can do the diagnosis and identify women that have high risk for this disease. Even here, it's very simple.
ایشون میگن حتی من در کشورهایی که بودم که حتی تشخیصات خیلی خوبی نداشتن دیگه برای تشخیص از طریق همون گرفتن نمونه ادرار بر بررسی پروتئینوری خیلی راحت میشد این رو تشخیص داد. پس نیاز نیست که حتما امکانات خیلی بالایی هم داشته باشید. Yes, please.
And we have to fix yet a very important definition. High blood pressure in pregnancy is defined as systolic blood pressure more than 140 and diastolic blood pressure more than 90 millimeters on 2 occasions at least 4 hours apart. This is a very important thing to know.
پس برای تشخیص این هستش که شما باید حداقل یک پروتئینوری که اولا که فشار خون هستش که سیستولیک بالای 14 و دیاستولیک بالای 9 باشه و همچنین حداقل با 4 ساعت فاصله دوباره این تایید رو شما پیدا بکنید. یعنی همین تفاوت بالا رفتن فشار بعد از 4 ساعت هم ببینید. Yes.
And we have to know that we have 3 ways to measure protein in the urine. And we have the simplest one is the dipstick. It's not the best one, but if you don't have any other way to measure it, you can use dipstick too, because you can use this if you are not inside a hospital or if you are a remote zone, you can use it.
روش‌های راحتی هست برای بررسی پروتئینوری. حتی شما میتونید از همین استیک ها یا از همین پچ های نمونه گیری که خیلی راحت مثل بیبی چک هست، یعنی منظورم هست، از اونا میتونید استفاده بکنید که در داخل ادرار میزنی و به راحتی میشه انجام داد. Yes.
Well, but not every hypertension is preeclampsia. Then we need to differentiate it, because although all of these conditions have high blood pressure, are characterized of high blood pressure, these diseases are not the same.
پس هر فشار خون پرکلمسی نیستش، یعنی شما باید حتما بر اساس این تشخیص هایی که اینجا خدمتتون میگم اینها رو بتونید تشخیص های افتراقی رو پیدا کنید. Yes.
There are many classifications, and in this figure here I present the classification from the International Society for the Study of Hypertension in Pregnancy. This classification was published just this year. Last year in 2021, and is very up to date. I think they didn't change the classification anyway, but it's important to know that there are other classifications too.
این دفینیشنی و این تعریفی که الان براتون گذاشتم جدیدترین تعریف فشار خون حاملگی و پرکلمسی هست که سال 2021 یعنی پارسال بیرون اومده و شما بر اساس این جدیدترین تعریف میتونید مریضتون رو کلاسیفای بکنید. Yes.
I will not explore this figure in depth because you should do that, and we can do this in another opportunity. But the most important thing to know is that in everyday life, sometimes it can be extremely difficult to differentiate these conditions. We can see here that we have at least 3 diseases: chronic hypertension, gestational hypertension, and preeclampsia.
بر اساس این تعریفی که سال 2021 و پارسال بیرون اومده، به خاطر اینکه واقعا خیلی سخته که بشه هایپرتنشن رو یا هایپرتنشن های مزمن رو و حتی پرکلمسی رو بشه از هم افتراق داد. بر اساس همین هستش که ما در اینجا بهتون میگیم که با این تعریف چقدر راحت بتونید این 3 مورد رو از هم افتراق بدید. Yes.
Yes, although we need just an equipment to measure blood pressure in a dipstick, sometimes there are some traps. In such case, caregivers should apply all their clinical skills to seek the right diagnosis with as much accuracy as possible. I say as much as possible. Sometimes it's not possible to make the right diagnosis. Sometimes we have to work with some degree of uncertainty.
در بعضی از کیس ها شما می‌بینید که اون مهارت های بالینی برای اینکه بتونید تشخیص درستی رو بدین خیلی سخته و باید خیلی با دقت فراوان تا اونجا که میتونید باید روش فوکس بکنید، روش تمرکز بکنید. به نظر آسان میاد، اما یه سری ترپ ها داره، یه سری راه ها داره که من در اینجا بهتون میگم که بتونید دقیقاً برسید به اون ریزالت، به اون نتیجه. Yes.
The first pitfall, it's related to equipment for measuring blood pressure in pregnancy. This equipment may be inaccurate sometimes. We know that the mercury sphygmomanometer is the best one, but it's not used anymore because it's dangerous, it's toxic, and it's not used anymore. Aneroid devices are used all over the world, and nowadays many people are using automated devices, and this is the problem. Not every automated device is validated for using during pregnancy.
همونطور که ملاحظه میکنید اولین پیتفال یا اولین موردی که باید شما خیلی دقت بکنید برای تشخیص اینکه اون دستگاه فشار خون که اکویپمنت و اون تجهیزاتی که میخوایم برای اندازه‌گیری فشار خون در بارداری استفاده کنیم ممکنه دقیق نباشه. اولین دستگاه فشار خون همون مرکوری هست که سمت چپ میبینین آبی بلند هست به خاطر اینکه سمی هستش توصیه نمیشه. دومی اندروید دیوایس هستش که خب خود انجام درستش خیلی مهمه، همه نمیتونن به درستی نصبش کنن. و سومی هم اون اتومات ها هستن که قابل اطمینان نیستن و دقیق نیستن. Yes.
I've forgotten to include here. There is an organization that checks the equipment for measuring blood pressure, and they up to date the brand marks that are useful, that are already validated. I will send it to you and you can share it with people, because it's very they make a very important job, that is to check if that equipment is validated for use during pregnancy. But
so
the
nice.
international okay.
نه دکتر. آقای دکتر میفرمایند که من حالا امروز یادم رفت بهتون بگم یه ارگانیزیشن و یه مؤسسه‌ای هستش که میاد حتی میزان دقت دستگاه‌ها رو بررسی میکنه برای فشار خون، فشار خون بارداری، که ببینن چقدر دقیق هستش، چون همه دیوایس‌ها قابلیت اعتبار درستی رو برای کنترل فشار خون بارداری ندارن. Yes.
Anyway, this brand mark here, MicroLife Cradle, is the cheapest and most accurate blood pressure device available to use in pregnancy. And this was recognized by this international society of hypertension, of study in hypertension during pregnancy. They agree with that, and they recommended this brand mark. I'm not marketing for them, it's important to say.
این دستگاه فشار خون مرکوری هم که دیدین خب بهترین استاندارد هست برای فشار خون بارداری، کنترل فشار خون بارداری، ولی خب دیگه به خاطر مسئله سمی بودنش دیگه در دسترس نیست. و خب میدونین که الان یه دستگاه جدیدی اومده به نام کریدل VSA که اینجا هم گذاشتن، که هم خیلی ارزون هست و خیلی دقیق هستش و برای استفاده در بارداری توصیه میشه. البته میگه من اینجا نمیدم تبلیغ این دستگاه این کارخونه رو بکنم، ولی یکی از بهترین برترین های سلامت جهانی هستش که حتی پتلت اوارد هم گرفته. Yes.
The second pitfall is white coat hypertension. Up to 1 in 4 patients with elevated clinic or office blood pressure have white coat hypertension. And sometimes we have to check it through home measurings, repeated readings, and nurse readings outside the clinic. And antihypertensives can be avoided, at least up to blood pressure levels too high. Anyway, we have to recognize that up to half will develop through gestational hypertension or preeclampsia, even when they have a white coat hypertension.
همونطور که میدونین یکی از 4 تا مریض با دارای فشار خون هستن که ما بهشون میگیم white coat hypertension. و اینکه در بین مراجعینتون ممکن شما حتی 50% مریض ها رو داشته باشین که 1% از فشار خون رو به شما نشون بدن. Yes.
It's very important to recognize this condition in order not to medicalize or to give a diagnosis to a woman that really don't has it.
این خیلی مهم هست که بتونید تشخیص بدین و یا اینکه بتونید به اون فرد، به اون مریضتون یاد بدین چجوری اندازه‌گیری در خونه انجام بده و بتونه ثبتش بکنه و در زمان مشخص اینها رو ثبت کنه برای شما بیاره تا بتونید شما اینو تشخیص درست برای مریض بدین. Yes.
The third pitfall. Sometimes diagnosis of chronic hypertension can be difficult. Chronic hypertension is defined as a high blood pressure predating pregnancy or before 20 weeks gestational age. It's easy when the diagnosis is previously known, but sometimes confusing if blood pressure before pregnancy is not known or documented. And this is what happens sometimes. I don't know many or sometimes. In Brazil, many times we have this situation.
سومین پیتفالی که باید خیلی توجه بکنیم این هست که تشخیص فشار خونهای مزمن هستش که خیلی هم سخت هست. چرا؟ به خاطر اینکه معمولا خانم‌هایی که فشار خون مزمن دارن، این فشار خونها معمولا قبل از 20 هفته حاملگی هم اینها دارن ولی پیدا نمیشه، مشخص نمیشه. خب این خیلی مهم هستش که ما بتونیم قبل از خلاصه از گذشته خانم داشته باشیم و گاهی اوقات هم خیلی گیج کننده است چون که فشار خون قبل از بارداری اصلا در این خانم انجام نشده و ثبت هم نشده و ما نمیتونیم دقیق تشخیص بدیم. Yes.
Due to physiological changes in pregnancy, blood pressure drops in mid-pregnancy and rises again in third trimester. You can see this figure is a classical figure. It was published more than 40 years ago, but I like very much this figure here. It knows what happens during pregnancy.
همونطور که ملاحظه میکنی یه تغییرات فیزیولوژیکی در بارداری اتفاق میفته که فشار خون بارداری در مید پرگننسی یه افت میکنه و بعد دوباره در ترد تریمستر افزایش پیدا میکنه. این چارتی که اینجا میبینین میفرمایند مال 40 سال پیشه ولی من خیلی دوستش دارم گذاشتم اینجا براتون. ملاحظه میکنین که جستشنال ایج در 12 هفته 12 رو 8 و بعد ملاحظه میکنین که تفاوت بالا رفتنش رو در هفته های 24 به بعد رو ملاحظه میکنیم. Yes.
Then remember that undiagnosed mild hypertensive woman may appear normotensive early in prenatal care, like you can hear it. And we could misdiagnose this case as preeclampsia or even gestational hypertension late if woman presents increased blood pressure later in pregnancy, like this case. We could easily misdiagnose this case here.
ما حتی ممکنه اشتباه هم تشخیص بدیم. همونطور که ملاحظه میکنیم مثلا ما میتونستیم میسدیاگنوز انجام بدیم این کیس رو، این همچین کیسی که اینجا هست رو به عنوان پرکلامسی یا بهش بگیم جستشنال هایپرتنشن لیت یا فشار خون حاملگی دیررس. باید این رو ما حتما در نظر بگیریم که در خانم هایی که هایپرتنسیو خفیف دارن و تشخیص داده نشده اینها ممکنه در مراقبت های بارداری هم تشخیص داده بشن، پیدا بشن ولی در 100% اینها فشار خون بارداری یا پرکلامسی نیستن. Yes.
And the fourth pitfall, to diagnose preeclampsia superimposed to chronic hypertension may be even more difficult. And in this case, you will have to use all your skills to differentiate it and to recognize its complications. Because up to 20 to 50% of women with chronic hypertension may have preeclampsia during pregnancy. And in this case, preeclampsia we will have earlier onset and will be more severe. Maternal and fetal prognosis is worse and management may be different.
دومین پیتفال این هستش که ما بتونیم تشخیص بدیم پرکلامسی رو از هایپرتنشن کرونیک یا مزمن که خیلی خیلی سخت هستش. پرکلامسی معمولاً خیلی قاطی میشه، خیلی سخت پیدا کردن تفاوتش با فشار خون مزمن قبلی. 20 تا 50% خانم ها معمولاً بالای 20 تا 50% هایپرتنشن مزمن دارن. و پرکلامسی معمولاً به این صورت هستش ممکنه که شروعش خیلی زودتر باشه و خیلی شدید باشه. در همچنین در اینجور موارد هم ما میبینیم که تشخیص مادری و جنینی هم خیلی بد هستش تو این موارد و مدیریتش خیلی مدیریت سختی هستش. تشخیص‌های مختلفی باید در اینجا ما در نظر بگیریم. Yes, doctor.
Then how to recognize that a woman who is already hypertensive, how to recognize that beyond chronic hypertension, this woman has also preeclampsia, because both of them are characterized by high blood pressure. We have to recognize that one disease superimposed to the other. How to do that?
واقعا باید ببینیم که اصلا واقعا میشیم چجوری تشخیص بدیم که واقعا این یک فشار خون مزمن هست یا فشار خون حاملگی و پرکلمسی هست. خیلی راحت نیستش و باید خیلی روی این مسئله دقت زیادی داشته باشیم. Yes.
Usually, a sudden increase in blood pressure that was previously well controlled or escalation of antihypertensive medications to control blood pressure. For example, this is a good example. Before pregnancy, this woman was already hypertensive. She used losartan 100 milligrams a day. During pregnancy, this drug was changed for methyldopa, and the doses were maintained the same until 30 weeks gestational age. You can see here that in the in this date, this woman presented an hypertensive crisis.
حتما باید توجه بکنید که ما یه تفاوتی هم در فشار خون خواهیم داشت اگر که مریضی داشته باشیم که داره قبل از بارداری با داروی ضد فشار خون کنترل میکنه بی‌پیش رو. مثلا در این مثالی که اینجا ملاحظه میکنید قبل از حاملگی این خانم با لوزارتان 100 میلی گرم در روز کنترل میشده فشارشون. در دوران حاملگی تغییرش دادن به متیل دوپا و همونطور که ملاحظه میکنید 12 هفته حاملگی رسیده فشارش به 14 روی 8 و در 30 هفته حاملگی رسیده به 18 روی 12. Yes, doctor.
This woman was admitted to the hospital, and after admission to hospital, we can see that day 1, day 2, day 3, day 4, we had to escalate medications to control blood pressure. And even though blood pressure was not controlled, in this case, even if proteinuria is absent, preeclampsia may be considered.
مثلا این مریض تا 30 هفته که ملاحظه کردیم فشار 16 روی 12 بود با متیل دوپای 1.5 گرم. بعد در بیمارستان بستری میشه. در لاین دوم ملاحظه میکنیم وقتی که ادمیشن در هاسپیتال میشه روز اول ادمیشنش متیل دوپای 2 میدیم بهش. روز دوم متیل دوپای 2 با نیفیدیپین 60 داده شده. روز سوم متیل دوپا با نیفیدیپین 80 و روز سوم هم با نیفیدیپین 120. ولی باز هم میبینیم که ممکنه یک مقداری از پروتئینوری دیده بشه و حتی گاهی اوقات هم اصلا پروتئینوری دیده نمیشه. برای همین ما باید در اینجا دقت بکنیم که ببینیم یا واقعا هنوز پرکلمسی هستش یا نه، همون فشار خون هستش. Yes, doctor.
Then these are the definitions of used for ACOG and ISSHP. And all of them say that there may be a sudden increase in blood pressure that was previously well controlled, or escalation of antihypertensive medications, or new onset of proteinuria. But the ISSHP don't recommend diagnosing preeclampsia superimposed only by a rise in blood pressure alone. They tell that one or more signs of maternal end organ dysfunction should be present. But this is a small difference. Anyway, the most important thing is to see that this woman is worsening.
همونطور که ملاحظه میکنین این یک تعریفی هستش که از پرکلمسی از ایکاک 2013 و ISHP 2014 اومده. ایکاک 2013 گفته که ما در صورتی فردی رو پرکلمسی میکنیم تشخیص میدیم که همراه با فشار خون مزمن باشه که شما یک افزایش فشار خونی که قبلا با دارو کنترل شده رو ناگهانی میبینی و در کنارش باید افزایش پروتئینوری رو باید در این خانم ببینی. و همچنین ISHP گفته که ما پرکلمسی رو به هیچ عنوان فقط با بالا رفتن فشار خون قبول نداریم. این تعریف رو باید یکی از عوارض ارگان‌ها و دیسفانکشن و عملکرد ارگان‌ها هم دیده بشه. Yes, doctor.
Well, you can see that until now, we are not telling about technology. We are telling just about clinical skills. We are talking about hearing the woman. We are talking about observation. We are talking about a relationship. And this is clinical skills. We have to know the clinical behavior of blood pressure, use of medications and its posology, its dose. And what we have is to talk with the woman, to know what things happened before pregnancy. And we have to look for woman's memories. During pregnancy, we have to look antenatal care. We have to look for our registrations. And after admission, if the woman is admitted to a hospital, we have to seek and to look medical and clinical and nurses and all personal registries.
همونطور که ملاحظه میکنیم ما اینجا اصلا در ارتباط تجهیزات اصلا صحبت نمیکنیم. فقط تو این مرحله داریم میگیم چجوری بتونیم از طریق رفتار کلینیکی فشار خون بتونیم تشخیص بدیم. همونطور که ملاحظه میکنیم ما از گذشته خانم فشار خون خانم باید در بیاریم. اول از همه باید اینها رو تشخیص بدیم، دقت بکنیم. قبل از حاملگی اون مموری ها و تاریخچه خانم در حین حاملگی مراقبت های بارداری درست میتونه اینو تشخیص بده و در زمان ادمیشن خیلی مهم هستش که ما مدیکال رجستریز ها و اون ثبت های پزشکی و موارد پزشکیش رو در نظر داشته باشیم با دقت. Yes, doctor.
Oh, people sometimes don't understand when I talk about this. When I say that to diagnose this preeclampsia, we need just an equipment to measure blood pressure and a dipstick. And then people ask me, what about laboratory tests? What about ultrasound? What's the meaning of this kind of technology?
در اینجا من میخوام اینو بگم که همیشه برای همه سوال هست. به من میگن که تو چرا وقتی که میخوای در ارتباط فشار پرکلمسی صحبت کنی فقط داری در رابطه با این صحبت میکنی که چجوری پیداش بکنیم و اینکه چجوری این رو شما متوجه میخوای بشی. من همینو میگم. برای فشار خون بارداری یکی فشار خون شما دستگاهش مهم هست که داشته باشید. دوم لیپستیک یا همون ورقه اندازه‌گیری پروتئین این برای شما کافیه و لازم نیست این همه خودتون رو درگیر بکنید. Yes.
Well, one thing is to diagnose. This is the first step. The second one is to classify severity of this disease. Is there end organ compromise? Is the disease any immediate threat to the pregnant woman or the fetus? If yes, an immediate action is needed. But if no, if patient is classified as non-severe, if disease is classified as non-severe, according to gestational age, we can observe and wait.
اگر که بیماری یک خطر خیلی ناگهانی هستش برای خانم باردار یا جنین، اول از همه شما باید در تشخیص پرکلمسی باید اول از همه تشخیص بدین و بعد کلاسیفای و دسته‌بندیش بکنین. خب به چه صورت؟ اگر خطر و تهدید خیلی سریع، جدی و خیلی ایمیدیت و ناگهانی هستش برای مادر و بچه، اگر yes جوابش بله هست که خب در اون دسته‌بندی سیویر و شدید قرار میگیره و باید سریع اقدام کنه. اگر خیر هست جواب، پس یعنی در دسته‌بندی خیلی جدی قرار نمیگیره و بر اساس سن حاملگی، شرایط بالینی مادر و انتظار میتونیم فرصت بدیم و بررسی رو ادامه بدیم. Yes.
It's important to note I'm talking about any immediate threat, because a threat, there is a threat anyway. Preeclampsia is a disease. We have seen that it can has its complications, but we are talking about an immediate threat. How can we identify signs of an immediate threat? Because this is the main goal of the clinician in this moment after diagnosing.
حواسمون باشه که در پرکلمسی حواسمون باشه که اون خطرهای ناگهانی و پیش بینی نشده رو سریع تشخیص بدیم و بلافاصله اقدام بکنیم. Yes.
Well, this figure, it's a very important figure. Preeclampsia is a multi-systemic disease that involves virtually every organ system. And in every organ, it has its own manifestations. We have to know all of them.
همونطور که میدونیم پرکلمسی یک بیماری مولتی سیستماتیک هست، این همه سیستم ها درگیر میکنه و در نتیجه هر ارگانی رو میتونه درگیر بکنه. پس ما اگر این رو بدونیم میتونیم تشخیص بدیم و آیدنتیفای بکنیم که ببینیم که چقدر این پیشرفت کرده و مارکرها و علامت‌های پیشرفت این بیماری رو بتونیم تشخیص بدیم سریع. Yes.
If we know them, we will be able to identify the markers of progression of the disease, and we will know that there is an immediate threat to the woman and the fetus.
اگر ما بتونیم به این دسترسی به این تکنیک دست پیدا کنیم، میتونیم از پیشرفت خطر در ارگان‌ها و تهدیدی که جنین رو میکنه پیشگیری بکنیم. Yes.
And now let's organize our thoughts. This is a method. The first, we have to look through the mother. We have to seek in the mother if it has signs of end organ compromise. And which are these kind of signs? We are at least three groups of signs. The first one is related to high blood pressure. If we have too high blood pressure, this is the first sign of end organ compromise or dysfunction. Secondly, signs and symptoms of significant end organ dysfunction that the most important of them, or the most frequent, the most common of them are these one: blurred vision, lighting, severe headache, altered mental status, and severe persistent right upper quadrant or epigastric pain.
4 تا علامت هستش که شما میتونید از آسیب به ارگان‌های انتهایی تشخیص بدید. اولیش که همون فشار خون خیلی بالا هستش که 16/11 هستش که سیستولیک 16 و دیاستولیک بالای 11 هست. دومین مورد علامت‌ها و سیمپتوم‌های عدم عملکرد مناسب ارگان‌های پایانی اند ارگان‌ها هست. یکیش همون تاری دید یا بلود ورژن هستش. یکی سردردهای شدید هستش. شرایط عدم هوشیاری ذهنی و همچنین درد 1/4 بالایی شدید قسمت شکم یا همون درد اپیگاستریک هستش. Yes, doctor.
Yes, and third, some blood tests abnormalities like platelets, liver enzymes, and coagulogram. These are the most important of them. But how accurate are these markers to predict adverse events in women with preeclampsia? Because although all of them are signs of end organ compromise, they don't have the same meaning, or the immediate threat is not the same. They have different meanings. We have to know them in order to make the best judgment and to take and to manage it the more adequate way.
مورد سوم تست ها هستن که به تست های خون هستن که به صورت ابنورمال دیده میشن، مثل پلاکت ها، آنزیم های لیور یا کبد و کوآگولیشن. اما اینکه آیا واقعا این مارکرها میتونه برای تشخیص و ایونت و شرایطی که میخواد در با خانم پرکلمسی ایجاد بکنه واقعا دقیق باشه یا خیر؟
For example, we say, I told you about severe headache, persistent headache. But what's really a severe headache? How to measure it? Because this is a symptom that only the woman is feeling. We cannot measure it. What is persistent? How long is maybe a headache to be called persistent headache? These are things that are not objective. And there is not really a universal definition, but we have to understand this.
ببینید مثلا یکی از همین سیمتوم ها مثلا سردرد هست. خب فردی که با سردرد مراجعه میکنه ما واقعا یک یونیورسال دفینیشن یا تعریف بین‌المللی نداریم. خب سردرد رو چجوری میتونیم ما تشخیص بدیم که چقدر شدید هست، علتش چی هستش و اینکه اصلا چقدر طولانی بود سردردش. یعنی واقعا نمیتونیم این رو ما میجر کنیم، اندازه‌گیری کنیم و بخوایم بر اساس اون خیلی دقیق بگیم این مورد پرکلمسی هستش. Yes.
Well, second, we have to look for the fetals. We have to estimate risk of fetal adverse outcomes, mainly fetal death. And in order to do that, we should use integrated testing which includes a Doppler study, cardiotocography, and even an ultrasound, and even fetal movement too. Fetal movement is a part of this kind of integrated testing. Usually, a baby that is moving inside womb is not indeed, at least don't has an immediate threat for fetal death.
مثلا شما که بخواید که وضعیت آتکام یا نتیجه جنینی رو بخواید ببینید آیا اصلا مرگ جنینی وجود داره یا خیر، خب ما باید از یه سری تست های خیلی منظم و یک نواخت استفاده بکنیم. مثلا توی داپلر شما ممکنه که بررسی آرتری آمبلیکال یا رگ جفتی رو بررسی بکنید، یا اینکه توی سونوگرافی میتونین بایوفیزیکال پروفایل رو بررسی بکنید. اما برای اینکه بخوایم این رو تشخیص بدیم خیلی مسئله یا حتی در CTG یا NST که ما میگیم همه اینها خیلی دقیق و ریز هست و گاهی اوقات حتی برای تشخیص دچار مشکل میشه و خیلی درست جواب داده نمیشه. Yes.
But to discuss the interpretation of integrated testing is beyond the objectives of this session. We can do this in the future too. I'm very anxious to increase our participation, and I'm very anxious about planning future sessions to you. I'm very anxious about that. We will do that in the future, Lily.
Yeah, sure. ما در با اینها در کلاس بعدی صحبت خواهیم کرد که چجوری با داپلر یا بیوفیزیکال پروفایل یا با فیتال هارت ریت و CTG میتونیم تا حدودی به تشخیص وضعیت مرگ جنینی یا خطرش پی ببریم که از بحث این حوصله بحث امروز خیلی خارج هست و تخصصی هستش.
Well, and now we arrived to the step 4. Don't remember a gestational age first. Make diagnosis. Second, classify, identify immediate threat to the woman and the baby, and 4, to define timing of birth. This is a very important clinical decision. I like very much this great Latin poet. In a poem of Ovidio, I've read that to know the right time is almost all the medical art. I loved this phrase, I loved this verse, because it applies too much to the obstetrics art, because we almost the time we are thinking and we are considering mainly when we have diseases to choose the best time. And we know that if we can wait, this is always good for the baby.
ما پس به 4مین مرحله رسیدیم. مرحله اول که گفتیم تشخیص بود، دومین مرحله دسته‌بندی بود، مرحله سوم پیدا کردن خطرات بود و حالا در این مرحله برای می‌رسیدیم که ببینیم زمان تولد کی هست. من خیلی این فریز رو و این جمله رو دوست دارم که میگه برای اینکه بفهمید زمان موقع زایمان کی هست، یک هنر پزشکی هستش. To know the right time is almost all the medical art. هنر پزشکی هستش.
Then after diagnosis and classification, we must to decide when to terminate pregnancy. Because if we consider only the woman, it should be always better to terminate pregnancy, but we have to consider the baby. Then we have to choose to wait, and this is called expectant management, or to terminate pregnancy soon after corticosteroids, and this is called interventionist management. What is better? How to decide?
ما به این مرحله میرسیم که خب بعد از تشخیص و دسته‌بندی ما تصمیم بگیریم که آیا کی باید حاملگی رو تمام کنیم، ترمینیت کنیم. اولین مرحله به این فکر میرسیم که خب صبر کنیم، به خاطر اینکه یک اکسپکتد منیجمنتی باید داشته باشیم. ممکنه که برای مادر خطر داشته باشه، ولی برای بچه هم باید در نظر بگیریم که آیا صلاح هست بچه رو از شکم مادر در بیاریم یا نه. دوم این که ببینیم که آیا باید ختم حاملگی رو زودتر از استفاده از کورتیکو استروئیدها انجام بدیم یا بهش میگیم اینترونشنیست یا با دخالت. پس این دو تا مورد رو باید در نظر بگیریم. Yes, doctor.
If we choose to wait, we have to know the risks, both for mother and for the baby. And when we choose that because we know that the baby has advantages.
تو مرحله ویت یا در مرحله اکسپکتنت منیجمنت یا مدیریت نگهدارنده، خب ما باید اول ببینیم که چه شرایطی هستش. حالا در یه سری ریسک هایی که ممکن در اونجا نوشته شده هستش ببینیم ادوانتیجز و مزایاش چی هست و ریسکاش چی هستش، که حالا مزایاش رو که اینجا توضیح دادن همه رو و ریسک ها، و بعد بر اساس این ما تشخیص میدیم که چه مدیریت نگهدارنده‌ای باید انجام بدیم. Yes, doctor.
And here in this figure, we have the recommendations for timing of birth that were issued by International Society for the Study of Hypertension, the ISSHP. I will not tell about this figure. We can study it in our material. We will share it to you. With you, but yes, I suggest you look this figure in depth when you have time, because here we have a synthesis. This is the recommendations according to the disease, according to gestational age. These are general recommendations, general laws or general rules.
این ریکامندیشن و توصیه هایی هستش که برای زمان تولد از انجمن ISSHP اومده که جدیدترین ها هستش، مال سال 2021 هستش که بر اساس سن حاملگی و پرکلامسی و همچنین جستیشنال هایپرتنشن و اینکه کرونیک هایپرتنشن، همه اینها رو توضیح داده در چه سن حاملگی و چه اقدامی باید بکنید درش اومده و شما بر اساس اون هر کدوم از این دسته‌بندی ها تشخیص میدین که آیا باید چه اقدامی رو انجام بدین. اگه وقت کردین حتما اینو مطالعه بکنین و این جدیدترین دستورالعمل هستش. Yes.
Anyway, timing of birth in pregnant woman diagnosed with preeclampsia or gestational hypertension or chronic hypertension should be the result of careful and ongoing assessment of maternal and fetal risks. That means clinical assessment of disease severity and gestational age.
همونطور که میدونیم پس زمان تولد در یک خانم حامله بستگی داره به پرکلامسیش، وضعیت پرکلامسیش و اینکه نتیجه اون اسسمنت، بررسی های در حال انجام و منظمی که از خطرهای جنین و مادر انجام شده که همون کلینیکال اسسمنت های میزان شدت بیماری ها و سن حاملگی هستش.
If the woman don't has end organ dysfunction, and this is a less severe disorder, and as a general rule, we could wait until at least 37 weeks.
خانم اگر بدون وضعیت هایپرتنشن خیلی، اگر خانمی باشه که با وضعیت هایپرتنشن غیر جدی باشه، خب معمولا مرگ مادر و جنین خیلی کمتر هستش.
But if the woman has end organ dysfunction, this is a more severe disorder, and decision is made case by case.
اگه خانمی دچار مشکلات ارگانی هم باشه باید تصمیم رو بر اساس هر کیس، بر اساس خود اون کیس گرفت، مطابق اون کیس.
But even then, it's very important to tell you that even when we have more severe disease, if we can observe them, most of the time we can wait, many times until 37 weeks too. And this is the kind of care we offer to our to the woman in our hospitals. Besides our hospital, we have a home. This is like a home, and many women stay there. The most important thing is to have a plan. We need a plan, a care plan. And these women here are cared by nurses, by midwives, and by doctors. And we have been caring for this kind of disease in the more physiological way too. This is important to admit. This is possible too.
Very nice. Fantastic. همونطور که ملاحظه میکنیم ما میتونیم فشار خونهای خیلی شدید و پرکلامسی ها رو حتی در شرایط شدیدش کنترل بکنیم، تحت نظر بذاریم. الان این خانمی که اینجا ملاحظه میکنید یکی از بیماران ما هستش که وضعیت پرکلامسی داشته با خیلی شرایط فیچر و تاثیرهای بد و خطرناک و جدی، ولی ما بیمارستان رو جوری براشون درست کردیم که مثل خونه است و داره توی بیمارستان به آرامی زندگی میکنه تحت نظارت پرستارها، ماماها و پزشک‌ها، بعد داره زندگیشو میکنه و حاملگیشو ادامه میده. در نتیجه یه کاری کردیم که مثل حالت فیزیولوژیک بشه بیمارستان براش و بتونه به فعالیت‌های روزانش ادامه بده و تحت نظر ما حاملگیش رو به صورت نظم با منظم با یه برنامه ادامه بده. اینجا الان ایشون در 37 هفته حاملگی هستش. به شرطی ما بلد باشیم که نقشه برنامه بذاریم و مراقبت درست داشته باشیم، میتونیم این کار رو برای مراقبت اینجور بیماران هم انجام بدیم.
And when we adopt this kind of care plan, what kind of signs we have to observe and how to take a decision? There are some algorithms and there are some figures that looks very complicated, but I think they can be simplified into very basic principles. And now we will use our hands and our fingers. And I will show you that things can be simplified And this is a friend I have in China, and this is a picture of from her. I like it very much.
Very
I
nice.
like her very much.
Lovely. ما الگوریتم‌های زیادی داریم که باید دربارش بدونیم که چجوری باید این کیس ها رو مدیریت کنیم. خب بسیار زیاده، خیلی پیچیده است. اما من دارم بهتون میگم یکی از همکاران من هستش که توی چین بهشون آموزش دادم. گفتیم 2 تا 3 تا انگشت 2 دست رو در نظر بگیریم، به همین راحتی میتونیم این رو تبدیل کنیم به 3 تا علامت در راست، 3 تا علامت در چپ و این رو کنترل انجام بدیم. Yes. کلاس داره کم کم.
Well, first use your right hand. This is the model. You have to make 3 ask 3 questions only. First, is blood pressure uncontrolled? Second, are there clinical signs or symptoms of end organ compromise? And remember that figure I showed you before. And third, are there laboratory abnormalities suggestive of end organ compromise?
خب اولین چیز دست راستتون هست. 3 تا انگشت دست راستتون رو در نظر بگیرید. این 3 تا علامت رو. 1. آیا فشار خون غیر کنترل نشده؟ 2. آیا علامت بالینی یا سیمتوم هایی هستش از ارگان های انتهایی که نشون بده؟ و 3. آیا آزمایش ها تشخیص های ابنورمالیتی از ارگان های پایانی رو داره میده یا خیر؟ Yes.
If the answer is no to all questions, usually there are no maternal criteria for terminating pregnancy, and we can observe. But if the answer is yes to any question, there we have to consider terminating pregnancy.
اگر در این 3 تا سوال 3 تا انگشتتون پاسخ نو بود، نبود به همه سوالات، پس هیچ نگرانی نداره و لازم نیست حاملگی رو ختم بدیم. اما اگر یکی از اینها پاسخ یس داده شده باشه، پس باید حاملگی رو ختم بدیم. Yes.
But how can we define blood pressure not controlled? Because we have to define this. Blood pressure not controlled is defined as persistently very high blood pressure, more than 160 and 110, despite use of antihypertensive agents at maximal dose.
خب چجوری تشخیص بدیم که اصلا فشار خون کنترل نشده هست؟ شما در صورتی که ببینید فشار خون بالای 16 یا 11 هستش، در کنار مصرف داروهای ضد فشار خون با میزان دوز بالا، این تشخیص داده میشه که فشار خون کنترل نشده هستش. Yes.
Unfortunately, there is no universal agreement about maximal dose. Canadian guideline use 3 antihypertensive agents over a period of 12 hours, but there is no agreement. There is no evidence about benefits and risks of adding a 3rd antihypertensive drug.
هیچ تعریفی درست بین‌المللی نیامده که اصلا ماکسیمال دوز یا دوز بالای داروی فشار خون چی هستش. SOGC در سال 2014 گفته که اگر 3 تا ایجنت و داروی ضد فشار خون برای مدت 12 ساعت مصرف بشه، به این میگن دوز بالا، ماکسیمم دوز فشار خون، داروی فشار خون.
For many years, we considered a maximal dose when using only 2 drugs, methyldopa and nifedipine. But since 2020, we have been adding a 3rd drug, and we only decided to terminate pregnancy when after using a 3rd drug, even though blood pressure is not controlled.
خب ما در مسائل ترکیزمون در طبابت خودمون معمولا به این صورت بودش که خب متیل دوپار و به همراه نیفیدیپین که داده میشد به عنوان 2 تا دارو بود، ولی الان گفته شده که اگر این 2 تا بود و داروی سومی اضافه شد میشه دوز خیلی بالای داروی ضد فشار. Yes.
And how to assess clinical signs and symptoms of and laboratory tests suggestive of end organ compromise. We can use the full Pierce calculator. I don't know if you know it, but this has been used all over the world, and its use is spreading in the world. And it's very useful because if the probability of adverse maternal outcomes is too high, pregnancy should be terminated. We have the link of this calculator. You can access it. And the most important predictors are chest pain, low blood oxygen saturation, thrombocytopenia, elevated liver enzyme, and increased creatinine concentration. And these are the things we put here in this calculator. It is already validated and it's very useful.
ما یه دونه کلکولیتر یا یه دونه تقویم یا ماشین حساب بررسی میزان خطر آزمایشگاهی رو توصیه می‌کردیم که اینجا عکسش تحت راست هستش. اما اون چیزی که خیلی فول پایرز داره تو همین داره خیلی روش اهمیت میذاره این هستش که شما این علامت‌ها رو در 48 ساعت اگر دیدین اینا رو روش باید تشخیص رو دیگه بذارین. اولین مهمترین پردیکتورها یا علامت‌هایی که تو اون جدول هم می‌بینین یکیش درد قفسه سینه هستش، لو بلاد اکسیژن سچوریشن هستش، ترومبوسیتوپنیا هستش، آنزیم‌های کبدی بالا رفته الیویتد هستش و بالا رفتن کانسنتریشن سروم کراتینین هستش. Yes, doctor.
We have already 1 hour of our session, but I'm already terminate. I'm already finishing.
Yes,
I know you may be tired.
No,
Well,
it's okay.
now raise your left hand. We used the right hand, now left.
حالا همگی دست چپتون رو بیارین بالا، 3 تا انگشت دست چپ.
And here too we have 3 questions. We have to check fetal growth. Is there intrauterine growth restriction or oligoamnios? Second, are there other markers of placental function? And then we use Doppler ultrasound of umbilical artery. And third, acute fetal vitality, CTG, and fetal movements. We have to check these 3 very important points related to the baby.
خب حالا میرسیم به دست چپمون. وقتی کلاسی داره تموم میشه این آخرین مبحث هستش. اینکه در انگشتان چپ 3 تا مورد رو باید بررسی کنیم که در رابطه با شرایط جنین بود. اون انگشتان راست مادر بود و حالا جنین. خب اولیش چی هستش؟ رشد جنین هستش. آیا بعد جنین IUGR هستش یا اولیگوآمینیوس هست؟ دوم اینکه دیگر مارکرهای عملکرد جفت رو بررسی کنیم که میایم توی داپلر آمبلیکال آرتری رو بررسی میکنیم و سوم اکیوت فتال وایتالیتی هست. شرایط جنین به صورت خیلی حاد هست که از طریق CTG و حرکت جنین تشخیص میدیم. Yes,
And finally, step 5, this is the last one. If we decide to terminate pregnancy because the risk is too high and we have a very severe disease, we have now to decide about mode of delivery.
Yes. و مرحله آخر خب دیگه مرحله خیلی مهمی هست و ببینیم چه روشی برای ختم حاملگی میتونیم انجام بدیم که مهمترین مرحله هستش. حالا سزارین یا زایمان طبیعی. Yes.
For severe preeclampsia, planned vaginal delivery or planned C-section delivery, what is better? There is no good evidence about that. No randomized controlled trial comparing C-section to vaginal delivery in patients diagnosed with preeclampsia was ever performed.
برای پرکلامسی سیویه یا شدید آیا زایمان طبیعی آیا باید انجام بدیم یا سزارین کدوم بهتره؟ هیچ اویدنسی در این سابجکت دیده نشده و هیچ کنترل رندومایزی هم دیده نشده که کدوم یکی از اینها انجام شده بر اساس کوچرین 2017. Yes,
many people all over the world think that preeclampsia means C-section, and that is not really true. If we look in the guidelines, and even if we look in the textbooks, in the very traditional textbooks, what is said is that the mode of delivery in women with gestational hypertension or preeclampsia, with or without severe features, should be determined by routine obstetric considerations.
خیلی از افراد فکر میکنن به محض اینکه شما تشخیص پرکلمسی رو دادین باید بلافاصله بریم برای سزارین، اما ما هیچ گایدلاینی نداریم و هیچ دستور عملی تا حالا نداشتیم که تایید بکنه که باید بره پرکلمسی برای سزارین. برعکس گفته میشه که باید با روتین obstetric consideration و اون تکنیک روتین با زایمان در نظر گرفته بشه.
But
Yes.
which are routine obstetric considerations? Well, routine obstetric considerations are maternal and fetal conditions and gestational age. And finally, what the woman think about that. We have to consider it too. These are routine obstetric, or at least these should be routine obstetric considerations.
خب روتین obstetric consideration یعنی چی که بر اساس اون زایمان رو انجام بده؟ یعنی اینکه اولی که وضعیت جنین چی هستش، شرایط مادر به چه صورت هست و خود مادر چی میخواد، چه تصمیمی داره. به این میگن روتین obstetric consideration. ملاحظات زایمانی روتین. Yes.
And this is my last slide. I hope this word means thank
too
you
much.
very much. I hope, because I search it in the Google Translator, and I hope this means thank you very much. I know preeclampsia is a complex disease. It can be challenging, even for experienced professionals. I hope well, my objective was to simplify some definitions and some concepts. I hope you have understood it. Thank you very much.
Thank you so much.
Lily, and
Thank you.
There.
آقای دکتر میفرمایند که این سپاسگزارم رو من از گوگل سرچ کردم که به زبان فارسی هست براتون گذاشتم و میدونم که پرکلمسی یک بیماری خیلی پیچیده است. سعی کردم خیلی سادهش کنم تعریفش رو براتون که از اون پیچیدگیش و اون اذیتی که اکثر متخصصین و ماماها باهاش میشن کمتر بشه براتون و راحت تر براتون جا بیافته. Thank you so much. خب دوستان عزیز، لطفاً ویدیوهاتون رو روشن نگه دارین. Thank you so much, Dr. Son. And so let's go to the chat box and have a look at chat box. Thank you so much. And I will try to review all of them. Yeah, thank you so much. Yeah, right here. Mehnaz from Iran, Azadeh Shiraz, Zahra from Karaj, Shaqaiq Iran, Ilham from Karaj, Irene from New Zealand. Irene is written, we must know both medical and traditional approaches. Medical approaches save lives. Fatima Anvari written, hello, Fatima from Iran, Rash, Mariam from Iran, Christina Abrams, hello from the USA, Philadelphia, PA, welcome. Will the recording be available after class is over? Yes, Christina. Just now it's streaming on YouTube as well. And Fatima Gholami, Irene, the house reduced stress levels. Stress increased too much insulin production, which constricts blood vessels, hence the high blood pressure. Yes, Fatima Anvari, thank you so much. Mohammad Nejad, thank you. They wrote only Farsi. Elahe Nazeri, thank you. Thank you. Mrs. Anvari, Flower and Smile, thank you. Rostami, thank you. Mariam Yehia, thank you for your lecture. it was great. Fatemeh, thank you so much. Dijen and Ralesia Paint, thank you. Dr. Etson, Ilham Sheikh, thanks. Mamnoon. Fatemeh Barzgar Sepas, thank you. Mehnaz, thanks. Shahnaz, thank you. Azadeh, thank you. Zahra, oh my God. Azadeh Zari, it was fantastic like always. Thank you so much, everybody. And thank you other non-Persian language bearing my voice during this translation. I know it's not easy to tolerate another language. Thanks a lot again, all of you. And thank you, Fatemeh. If you have any question, اگر سوالی دارین توی چت باکس بنویسین. دوستان عزیز، برای گواهی اسامیتون چک میشه، ساعت حضورتون چک میشه و عزیزانی که ویدیوشون تمام کلاس روشن بود و اسمشون با ایمیلشون یکی بود، به همراه اون مبلغی هم که بعد پرداخت کنن قبضش رو که برای گرفتن ریفرال نامبر هست بفرستین، انشاءالله گواهیاتون تا یه هفته خدمتتون ارسال میشه تو گروه واتساپ و کانال تلگرام. Everybody, if you're interested to have certificates, so first of all, you have to send your email address and your name and your profile and your DP should be exactly similar with your email address. We will provide your certificate in 1 week. Thank you so much. Please, if you have any question, write in chat box. Yes, Gail, please. Fatemeh written, we can speak about you and hypertension next time. Sure, Fatemeh, tomorrow morning, 12 noon, we have yoga. Okay, sure. Yes, yoga.
Yes, I like
yeah,
it
please.
very much, this idea, yoga and hypertension, because I've talked something about treatment, but in the point of view of the medicine, we know that we can manage it. We can include other kind of treatment too, and in order to decrease the severity of the disease and to prolong pregnancy should be our objective ever, because there are always advantages for the baby. And yes, Gail, hello.
Hello. Okay, a bunch of things popped into my mind. First of all, in the first trimester, I like to counsel and find out how healthy my mother is to begin with. I mean, is she eating well? Does she have malnutrition? What is causing high blood pressure? What is causing preeclampsia symptoms to come up? I don't think we focus enough in the medical world in prevention. And I think we can prevent preeclampsia from happening and the HELP syndrome a lot of the times by changing nutrition. I did see on one slide, it says, observe and wait. Well, my goodness, if I'm observing the potential problem, why am I going to sit and wait? I want to work on prevention right then. What is happening? And how can we change her life? How can we change her situation? But that starts when a woman is 6 weeks pregnant and pees on a stick. That's when we need to start talking with her, finding out how she is healthy right now to possibly even avoid the situation.
Yeah.
And we cannot do that unless we have more midwives in the back of bush, more midwives in the field, more midwives understanding the family dynamics. So I love when a doctor steps in and has medications to help in crisis. But I don't like the idea of observe and wait. Maybe observe and let's see what we can do.
Yeah.
Not just observe and wait for a crisis. I think that's the difference in my thinking.
Yeah.
I need all of the medicines and what doctors can happen when it's crisis. I want not to have a crisis.
I agree with you, Gail. On that respect, I can share a journey with you. I love the way Edison brings everything across and makes it very simple for us to understand, because we do need to understand the medical approach. because there are some cases that we can't prevent, but the majority, and I know 95% of my women had normal and complicated birth. How long have we got, Lily? Can I take you on a little journey?
Actually, our time is over, but if you want to at some point, why not? We enjoy. Yeah, sure.
Okay. So I'm going to take you back to the 1970s when I trained in the hospitals in the northeast of England. It was a very poor poverty area, and we saw lots of high blood pressure, preeclampsia. It was the days of heminephrin and dark rooms, and we used to nurse the woman one-to-one with the epileptic tray in the room, and they used to
sorry, shall I translate or no need to translate?
And then, well, they used to, if you want to translate, you can translate.
Just I will explain short brief.
I'll talk slowly.
Yeah. خانم ایرنه میخوام براتون یه سناریویی رو تعریف کنم. سال 1917 که در انگلستان بودن کار میکردن و میزان خیلی بالای فشار خون حاملگی با استفاده از داروها و دخالت‌ها برای کنترل اون رو داشتن در اون سال در انگلستان انجام میدادن. Yes, please.
Okay, so we used to stabilize the women, and then they would they would birth the woman. So we didn't have a lot of C-sections, but there was a lot of women with high blood pressure. So in 1982, I went to Saudi Arabia, and the Bedouin women were just moving from the desert into the hospitals. And I thought, oops, we've got 3,000 births here, and no preeclampsia, no high blood pressure. What's happening here? What is it with these people? You know, it's like everything was really, really more normal. We had 90% normal birth rate, and we didn't do anything. Women would come in and birth, and the baby would be in their bloomers, and the family knew what to do. So then I thought, there's something different. Why are we getting all this high blood pressure in the UK and we're not getting it here at the moment? And it wasn't until I went back to Saudi in 1995 when I started to see the medicalization of birth. I saw women walking around the hospitals with high blood pressure, epidurals, larger babies. It was the diet. We introduced the KFCs, the takeaway foods, the fruit juices, the rice. I mean, the Bedouin women in the desert, they didn't eat rice. You know, so I could see that difference. So it took me on a journey to say, well, the first thing we need to look at is the diet. Now, from there, I ended up, when I went back to England, and then I went back to I got the job in New Zealand, and it was the same thing. In New Zealand, we were flooded with women with high blood pressures and lots of complications. And I was looking at the cultures, and it was mainly our women from India, because in Indian women who are vegetarian are very healthy in India. They eat root vegetables. It's very different. I don't know what the eclampsia rate is in India in this present day, but in New Zealand, it's very high because they eat a lot of sugar, chapatis, rice. They have a sweet tooth, and I always say you can blame the British. We took it to India. So a lot of these women were having the complications and high blood pressure. So we turned the diet around and the lifestyle, and we reduced the problems. So this is part of my jigsaw puzzle coming together. You can explain that if you want to translate that.
That's fantastic experience. خانم ایرنه میفرمایند که من در سال 1971 یعنی تقریبا 40 سال پیش که انگلستان کار میکردیم میزان خیلی بالایی ما از پرکلمسی داشتیم. یه حدود 10 سال بعد که رفتیم توی صحرا شروع کردیم کار کردن، توی محیط صحرایی بود و امکاناتی نبود و شهری نبود، میدیدیم همه تبدیل به زایمان طبیعی میشه و اثری از فشار خون حاملگی نمیبینیم. بعد دوباره در سال 1900 فکر میکنم 90 اگه اشتباه نمی‌کنم یه 7-8 سال بعد دوباره در نیوزلند اومدیم دیدیم که میزان فشار خون حاملگی رفته بالا و می‌دیدیم که سطح‌های KFC و غذاهای فست فود داره میاد و ما به این نتیجه رسیدیم که علت اکثر چیزها از غذا هست. حتی الان در جامعه هندی ها شما ملاحظه میکنید که میزان فشار خون حاملگی بالاست به خاطر اینکه خیلی از نون و چربیجات و سیب زمینی استفاده میکنن که ما انگلیسی ها آوردیم تو هندوستان و اینها آلوده شدن و این دقیقاً به سبک تغذیه هم بستگی داره. Thank you so much. Christina is writing something. Yeah, please.
Yeah. So that then took me onto a journey to look at, well, if this is happening and it's all lots of sugar, what does sugar do? What does the environment do? So then I moved on to look at insulin resistance. Okay. So I was looking at the environment and everything else. So the insulin resistance, you know, if you're stressed, it's like eating a bucket full of sugar, which pumps out the insulin. And later I'll talk a little bit about nitric oxide because that reduces nitric oxide levels, which constricts the blood vessels, which causes the hypertension. Okay, so that kind of makes sense. Okay, so what I was looking at, because environmental toxins, so when I studied homeopathy, because that came into it then, it taught me in the holistic side of things is that hypertension is a symptom of an underlying condition, and that can be emotional, environmental, spiritual, dietary. You know, so you have to look at, well, what is it about this woman that's making this blood pressure go up? You can just explain that.
بعد یکی از مواردی که در تغذیه دیدن خب میزان شکری که داره استفاده میشه در هندوستان و در این کشورها خیلی بالاست. خود شکر باعث میشه که انسولین رزिस्टنسی ایجاد کنه و فرد وقتی که قندش میره بالا با خوردن شکر نیاز پیدا میکنه که نیتروژن پروکساید رو استفاده بکنه، در نتیجه باعث میشه فشار خون بالا بره. بر اساس کارها و تحقیقاتی که انجام دادن به این نتیجه رسیدن که فشار خون مجموعی هست از استرس ها و شرایط ایموشنال، انوایرمنتال یا محیطی، اسپریچوال یا روحی و روانی و تغذیه. تمام اینها در تحت تاثیر قرار میده این فشار خون بارداری رو. Yes.
So it then linked me on to looking at small for gestational age because I went to these courses and I started to study the anatomy and physiology of the placenta and realized that the placenta can regenerate until it gets to the point where the maternal blood supply shuts off to the baby. So what's causing that to happen? It's the constricted blood vessels that are preventing the flow to the baby. Yeah. So if we can fix the diet and increase the nitric oxide levels, which I'll talk about shortly, then maybe we can regenerate this if we catch it early enough. If we give dietary prevention on emotional, physical, and spiritual wellness and diet in early pregnancy or even to teenage girls in school, okay? So that was the other thing. So then I decided to go out from hospital into independent practice. And I went to visit a woman at home for my friend. So I walked in the house, took a blood pressure, which was 180 over 110 with 3 pluses of protein. I went, what do I do here? This is my first case in the community. So I rang my friend and said, we've got to send her in. We have to go in. This is something that's happening really quickly. So we go into the hospital and we induced her. Now, if it's a true eclampsia, if you induce the woman, she will go off like a bullet. And this woman delivered within 1 hour of putting the prostaglandin gel in. But then we had another problem because she had a paralytic thing at the side of her face. And I said, oh my goodness, I hope we didn't put some lignocaine into a blood vessel when we sutured her perineum. And the anaesthetist came in and we said, why is this woman's face getting more paralyzed? She had a stroke. She developed a stroke, okay. And she had a Swedish accent and her whole left side was paralyzed. But we then took her history. She had rheumatic fever when she was younger, and she was treated by a naturopath, and her heart was never checked afterwards. Okay, so when you take a history, you have to take an entire history of environmental, physical, and say to the woman, have you ever been so sick that you could never get out of bed? Okay. Another woman I had was, she called me, her blood pressure had been up, it was 150 over, it was 150 over 70, and then it settled itself down and everything was normal, and her tests were normal. But she rang me 3 days later and said, oh, you're going to be angry with me, I've eaten a KFC. And now I've got some epigastric pain. So I thought, well, she's eaten that, just wait an hour, it might settle down. If it's no better, you go to A&E. Mm-hmm. Well, she didn't get back to me. She took her own blood pressure, which was high, at home, and she took herself into the emergency department 6 hours later. And she had something I'd never seen before in my life, because it was wave-like pains, like the gallbladder was inflamed and it was going through this wave. And I think we put it down to eating the fatty meal. But she ended up on intensive care unit and her liver ruptured. And I looked at her history again. She had had liver issues before. She'd had hepatitis A. It was her diet before. And in my eyes, it was acute fatty liver of pregnancy, which we don't seem to look at. And that again comes from poor diet. So I think we need to have more looking at what is really happening with the liver and her diet. Because with insulin resistance, we do get, in poor diet, we get acute fatty liver. So it's one of the things that can masquerade it. So that's just another thing to look at.
Yeah, sure. Very nice. Thank you so much. Lovely.
You want to translate it?
Actually, no, I think that if I want to translate, it takes a long time and people want to leave. I prefer to read these passages. Christina Abraham is written, many women are dying in the US because doctors are not listening to the secondary sign of organ failure, mostly women of color. It is like either the physicians are unaware or they don't believe them. Oh, midwife and supplemental birth workers, doulas, are frustrated.
Yes. I'll just finish a little bit on nitric oxide, if that's okay. Okay. Yes. Just a little bit, because, you know, things fall into me, because when I looked up diet and hypertension, I found a research paper from Zulino et al. 2018, which is part of the book. Nitric oxide is a key regulator of both maternal and fetal homeostasis during pregnancy, facilitating the maternal cardiovascular changes, fetal development and growth, and adaptation to extrauterine life. Dysfunction of the nitric oxide system during pregnancy is associated to placental and vascular-related diseases such as hypertensive disorders of pregnancy and intrauterine growth restriction. So we have to look at, well, what is causing this? And when I went through the research, I'm not going to go through all of it, but nitric oxide levels, when they are reduced, they constrict the blood vessels. Can't hear you.
That's
Lily?
okay. No, yeah. I'm
right.
explaining
yes.
So
if we have too much and too much nitric oxide, which can be given if we give too many supplements at the end of pregnancy, we're going to get hemorrhage. So I'll post this if you want it, but it's in the books that I've just written. But just let me cover the diet, because I think that's really important, okay? So nutrition plays a very, very important part. The research paper I found was actually looking at nitric oxide supplements, which I don't totally agree with, because I think you have to go back to the diet and fix the problem. Okay, so iron deficiency reduces nitric oxide. but too much iron can increase it. Okay, so if we're anemic, they usually say that we're more prone to hemorrhage, but a lot of anemic women don't hemorrhage. It can work the opposite direction. Okay, this comes from Wu and Menninger 2002. I'm hoping that we can arrange and Edson and the team can do more research on what I've found here. Protein, low protein intake results in decreased nitric oxide production. Protein deficiency can lead to hypertension and a compromised immune system, but too much protein can increase nitric oxide. Glucose. Hyperglycemia plays an active role in the development and progression of endothelial dysfunction in diabetes. Nitric oxide production is dependent of glucose as a source, but hyperglycemia inhibits nitric oxide levels. So that makes sense. Hyperglycemia, too much insulin, reduced nitric oxide and constricted blood vessels, which lead to hypertension. This comes from Wu and Menninger in 2002. Then we're looking at fructose. So a lot of women have sweet tooth, so they shouldn't eat too many of the fruits that are high in sugars, in fructose, okay? The high levels of fructose inhibits endothelial nitric oxide production, which again may lead to hypertension, okay? Constricted blood vessels. And then you've got the saturated fats, okay? The saturated fats from takeaway foods do the same thing. They contribute to diabetes, increase the blood glucose levels, and also reduce nitric oxide levels. But if you give the fish, eat lots of salmon and fish and the healthy fats, actually, it increases the levels. So we usually get women to eat lots of fish, okay, and salmon and things like that. So the vitamins C, A and E and folic acid are increased nitric oxide production. So if you've got you don't want too much and you don't want too little. Calcium. It's contradicted. One manager in 2009 said that if we give too much calcium, it attenuates the development of hypertension in rats. So sometimes we keep saying you need more calcium, but we need to look at, are we giving that right advice? And we need more research on that. Zinc, okay, zinc is very important. And if you go to diabetes, which is linked to hypertension, the three main things that are missing are zinc, protein, and magnesium. And it repeats itself here and with the reduction of nitric oxide levels. So magnesium as well is dose dependent for the stimulation of nitric oxide. We shouldn't give glucosamine in pregnancy because it can create cardiovascular complications in diabetic and obese subjects. And we need to encourage women to eat plant-derived isoflavones such as soybeans, chickpeas, fava beans if you've not got thalassemia, nuts, pistachios, and things like that, which can actually increase the nitric oxide levels. End of story. I'd like to hear your comments.
Yeah, it was interesting. So interesting. Yeah, lovely. I will translate later for Iranian because it was very fantastic topics that I was enjoying really. دوستان عزیز چون خیلی متن جالبی بود من بعداً براتون ترجمه‌اش میذارم که با مقاله‌ای که چقدر تغذیه میتونه تاثیر بذاره روی فشار خون و اینکه استفاده زیاد از مولتی ویتامین ها در پایان بارداری باعث هموراژی میشه و تمام اینها رو داشتم در این تحقیق توضیح میدادم. ان شاء الله توی استریم این برنامه نگاه کنید و بعد دوباره این تحقیق زیبا رو یه ریویوی بفرمایید. Thank you so much.
So just one more, just antioxidant foods such as and beetroot juice and pomegranate can reduce blood pressure.
بعد میوه های آنتی اکسیدان میتونن میزان فشار خون رو پایین بیارن. That's fantastic. Lovely.
Okay, so if you're in the hospital, the woman lying in the bed who's got 5 children with a high blood pressure on medication in a room by herself, she was so stressed and her blood pressure was high, so we gave her the beetroot juice and changed her diet, and she didn't need the medications. It all settled down. She was able to go home and gave her the fish. Yeah.
Lovely, lovely. Thank you so much. Yes, Dr. Edson, I suggest you schedule a meeting about preeclampsia prevention. Yeah, why not? Lovely. Irene could talk about that. Sure, sure. Thank you so much. Thank you, everybody. Thank you, Dr. Edson, Gail, Irene. Thank you, Dr. Nilufar. Tomorrow, next 13 hours, we will have yoga. It's International Youth Day with Dr. Nilufar Farivar. She's here already. And we will meet you in next 13 hours with dance, yoga, and for all family. Please invite your friends, family, and anybody wants to have 1 hour yoga session with Dr. Nilufar Farifar at Scientific Board. Thank you, everybody. Thank you so much. Dr. Edson, it was wonderful.
Love you all. It was beautiful.
Love you all. Be with us.
See
Thank
you tomorrow.
you. Have a nice day.
Tomorrow night.
See you in next 13 hours, guys.
God bless. God bless everybody. Peace, love,
Thank
and
you
light.
so